Hello, everyone, and welcome to our module on cerebral strokes. Let's start by talking about what we mean when we refer to a cerebral stroke. So, strokes in general refer to clinical syndromes where patients develop the sudden onset of neurologic dysfunction, either motor loss or sensory loss. And strokes are caused by loss of blood flow to a region of the brain, and there are two general patterns by which this happens. One way this can occur is when there's obstruction of blood flow to a region of the brain. These strokes are called ischemic strokes. The other way you can get a stroke is if there's rupture of a blood vessel that leads to bleeding into the brain, and these are called hemorrhagic strokes. In this video, we're going to focus on cerebral strokes, and by that I mean strokes where the affected region involves the cerebral cortex. There are also strokes that involve the brainstem and the spinal cord and other parts of the brain besides the cerebral cortex, and I talk about those strokes in other videos. So to understand cerebral strokes, we have to first review the blood supply to the central nervous system. And we broadly divide the blood supply to the central nervous system, including the brain, into two halves, the anterior circulation and the posterior circulation. So if you look at these drawings in the slide, this is a depiction of the brain, and it shows the blood vessels that deliver blood flow to the various regions of the brain. And over here is a blow-up of that vascular system where all the vessels are labeled. So one of the major structures that delivers blood to the brain is the circle of Willis. And you can basically think of the anterior circulation to the brain as everything above this line I'm drawing with my pen, including the circle of Willis. That's where most of the blood supply to the anterior portion of the brain comes from, and that's why it's called the anterior circulation. All the vessels in the anterior circulation get their blood flow from the aorta via the internal carotid arteries. That's what fills this whole region, the anterior circulation, with blood, and that goes on to supply blood to the anterior two-thirds of the cerebral cortex. So this includes things like the frontal lobe, the parietal lobe, and also the lateral temporal lobes. And in terms of strokes, the two major blood vessels in the anterior circulation that lead to stroke syndromes of the cerebral cortex are the middle cerebral artery, shown here, and the anterior cerebral artery, shown here. In contrast, the posterior circulation is everything down here. It gets its blood supply from the aorta via the vertebral arteries, which then fill the basilar artery. And so this is the vertebral artery here. There's another one on this side, and they come together to form the basilar artery. And that's what delivers all the blood flow to the posterior circulation of the central nervous system. And so the posterior circulation is much more important for structures like the brainstem and the cerebellum. It only has a limited role in supplying the cerebral cortex with blood flow, and that's via the posterior cerebral artery. That's what's shown right here in this image. And that supplies blood to the occipital lobe and the medial temporal lobes. So when we're talking about strokes of the cerebral cortex, we're going to be focusing on the ACA and the MCA, which are part of the anterior circulation, and also the posterior cerebral artery, which is part of the posterior circulation. So in just a minute, I'm going to talk about specific cortical stroke syndromes, but before we can get into that, we have to talk about something known as the homunculus. Homunculus is a Latin word that means little man, and it refers to the way that the motor and sensory neurons are laid out in the cortex. So to understand this, let's look at this drawing on the slide here, which shows a cross-section through the central nervous system. We have the brainstem and the medulla down here. This is the pons and the cerebellum here. And up at the top, we've got regions of the cortex. And this cross-section is showing a slice through the primary motor cortex, where you find motor neurons, upper motor neurons, that innervate muscles of the body for motor function. And then over here on this side, we have a depiction of the motor homunculus. So let's talk about what this means. So here in the region shown in green, you can see there's a drawing of a leg and a foot. And that's telling you that in that region, you find upper motor neurons that go on to control the legs and the foot. In contrast, over here in yellow, you've got a drawing of an arm and a hand. And so you find motor neurons in this region that are upper motor neurons that control movement of the arms and the hand. And then you've got a face right here representing motor neurons in this region that control muscles of the face. And so this homunculus is essential for understanding the motor and sensory defects you see when different blood vessels are involved in cerebral strokes. If you have a stroke involving the anterior cerebral artery, that's going to affect everything in green shown here, which you can see from the homunculus refers to the legs. So in anterior cerebral artery strokes, you get damage to the medial frontal and parietal lobes. That's this region in green. That's the leg area of the homunculus. And so the major feature of ACA strokes is contralateral leg weakness. And this is because of the homunculus and the way these motor neurons are laid out. In contrast, the middle cerebral artery supplies blood to everything shown in yellow here. So if you have a stroke involving the MCA, you're going to get damage to the lateral cerebral cortex. That's this yellow region over here. That's the face and arm area of the homunculus, and so the dominant feature of MCA strokes is contralateral face and arm weakness more than leg weakness. And then in case you're wondering, the posterior cerebral artery, or the PCA, mostly supplies the occipital lobe, which is involved in vision, and so that generally leads to vision problems, not problems with motor and sensory function in the extremities or the face. Okay, we're almost ready to talk about specific cortical stroke syndromes, but before we do that, we have to review one more thing, and that's cortical signs. So cortical signs are signs on physical exam of patients who've had a stroke that indicate the ischemic area involves the cerebral cortex. All of these cortical signs I discuss in detail on the video on the cerebral cortex, but I'll just briefly review them here because you need to remember these in order to identify patients who have a cortical stroke. They will have cortical signs on exam. So one cortical sign is Broca's aphasia or Wernicke's aphasia. These signs always indicate that the ischemic area of a stroke involves the cerebral cortex. And that's because Broca's area is found in the left frontal lobe and Wernicke's area is found in the left temporal lobe. So anytime you see one of these forms of aphasia, right away you know that stroke involves the cortex. It's not a stroke limited to the brainstem or the spinal cord or something like that. Hemi-neglect is another cortical sign. This refers to damage to the parietal lobe. I talk about this in detail in the video on the cerebral cortex. Gaze preference is when the eyes deviate to the side of an ischemic lesion. This happens when there's damage to the frontal eye fields. This is another cortical sign. And then finally, homonymous hemianopsia, which is a specific type of vision loss. We'll talk more about this later. That indicates damage to the occipital lobe. So the reason it's important to know what the cortical signs are is because if they're present on physical exam in a patient with a stroke, they tell you that the stroke involves the cortex. Maybe more importantly, they tell you that the stroke is not localized to deeper structures like the internal capsule or the brainstem. Strokes involving these regions do not produce cortical signs. So when the cortical signs are present, you know that the stroke can't be confined strictly to these regions alone. And then another feature you can detect on physical exam in stroke patients that's not technically a cortical sign, but it can be very helpful for localizing where the stroke is occurring, is so-called dense hemiparesis. This refers to complete weakness of the arms, legs, and face. You generally don't see this in cortical strokes. As we talked about earlier, cortical strokes involve damage to some part of the homunculus, but usually not the entire homunculus, so you don't get complete weakness of the arms, legs, and face. In order to get that dense type of hemiparesis, you need to have damage to some lower region below the cortex where all the motor fibers are running together. So you can see this when there's injury to the internal capsule. You can see this when there's damage to the corticospinal or corticobulbar tracts. You sometimes see this in lacunar strokes, which are deeper strokes below the cortex, and we'll talk about these later. But in general, dense hemiparesis is usually not a clinical finding in a patient who has a cortical stroke. Okay, so now we're ready to talk about specific cortical stroke syndromes. And if you understand everything I just told you about the homunculus and cortical signs, these stroke syndromes are very easy to understand. So we'll start by talking about a middle cerebral artery stroke. This is the most common site of stroke. It leads to contralateral motor and sensory symptoms. Because of the homunculus, which we've already talked about, the symptoms tend to involve the arms and the face much more than the legs. The region that's damaged in the cortex contains upper motor neurons, so patients develop spastic upper motor neuron type paralysis. And then there will be cortical signs present in most cases. If it's a left-sided MCA stroke, patients will develop aphasia, and that's because the speech center is left-sided in most patients. They can develop Broca's or Wernicke's aphasia depending on which region is affected. If it's a right-sided MCA stroke, this is the non-dominant side in most patients, and that will lead to hemi-neglect. And shown on this slide is a CT image from a patient who had an MCA stroke. You can see this huge territory here of the cerebral cortex, which is dark. That means it's been affected by ischemic damage. And this is the region that can be damaged in patients who have MCA strokes. Now, we've already talked about the homunculus and how the MCA region of the homunculus has motor neurons that control the face. And so that will lead to weakness of facial muscles. But let's talk about exactly how that presents. And the way it's going to present in an MCA stroke is with lower facial droop. So let me tell you what I mean by this. So the upper part of the face, meaning the forehead, has dual upper motor neuron supply from the right and left side of the brain. But the lower face, below the forehead, has a single upper motor neuron supply from the contralateral motor cortex. These fibers run in the corticobulbar tract. So if you have MCA stroke damage, there will be upper motor neuron damage to the neurons that supply the muscles of the face. But the upper face is not going to be affected. It has a dual supply from the opposite side. Only the lower face is going to be affected. So patients with MCA strokes develop weakness of facial muscles, and the way that presents is as lower facial droop. And that's what's depicted in this image here of this woman. So her forehead is equal on both sides, is not drooping at all. But then if you look down here, she's got droop on this side of her face, but does not have it on that side. So she has lower facial droop, classic finding in an MCA stroke. And the reason this occurs is because the forehead region up here has dual upper motor neuron supply. Okay, next let's talk about an anterior cerebral artery stroke. This is the second most common stroke site. Just like MCA strokes, this will lead to contralateral weakness and sensory loss, but the pattern is different because of the homunculus. Region affected in terms of motor fibers in anterior cerebral artery strokes is this green region right here, which has motor neurons for the legs. So patients with ACA strokes tend to develop leg weakness and sensory loss that is greater than the weakness and sensory loss of the arms and face. Other features you can see in an ACA stroke are, first of all, urinary incontinence. That's because there's a micturition center that helps control urination in the medial frontal lobe, and it's often damaged when you have damage to this green region shown here. And then the ACA also supplies a lot of the frontal lobe of the brain, which is where our personality comes from. So personality changes can occur in patients who have ACA strokes from frontal lobe involvement. This can involve lots of different things. It could be apathy, it could be disinhibition, but the bottom line is they all represent personality changes because of frontal lobe ischemia. Okay, and then the third and last major vessel that supplies blood flow to the cerebral cortex is the posterior cerebral artery. This is unique in that it supplies the cortex, but it's part of the posterior, not the anterior circulation. And the PCA supplies the occipital lobe, which has our visual cortex. So most of the clinical features of PCA strokes are visual. So things like hallucinations, agnosia, which is seeing things but can't recognize them. You can also get a special pattern of visual field defect called hemianopia with macular sparing. I talk about this in more detail in videos in the ophthalmology section, but the visual field defects look like what I've shown in the slide here. The black regions are parts of the visual fields that are absent. So patients lose half of their visual field, but the macula, which is the high resolution central vision, is spared because it has a dual blood supply from the MCA and PCA. So this little high resolution region in the center can be spared. And once again, I talk about visual field defects, including this type of visual field defect, in the videos in the ophthalmology section. Another thing to know about posterior cerebral artery strokes is that the posterior cerebral artery supplies the lateral thalamus. So sometimes when there's PCA ischemia, this can lead to a clinical syndrome known as a thalamic syndrome. It's also sometimes called Dejerine-Rossi syndrome. This is basically a sensory syndrome related to damage to the thalamus. So patients who develop a thalamic syndrome from a PCA stroke develop contralateral sensory loss that involves the face, arms, and legs. All sensation except for smell from all regions of the body goes through the thalamus. So when it's damaged, you can have sensory loss to all these areas for all sensation except for smell. One of the things that's sometimes most noticeable is the proprioception defect. This can lead to loss of balance and falls, and then a workup can identify that the patient isn't sensing lots of things in their face, arms, and legs because of damage to the thalamus. Importantly, though, there are no motor deficits, all right? So there's no motor control that relays through the thalamus, only sensory information. And then long term, when patients have ischemic damage to the thalamus, they can develop a chronic pain syndrome on one half of their body, which has peculiar symptoms related to pain and sensory perception. So some of the things that patients can develop is, first of all, allodynia. This refers to a situation where ordinarily painless stimuli cause pain. So for example, just touching the skin on someone's arm can cause pain. That's allodynia. You can see that in someone who's had a thalamic stroke. You can also see dysesthesia, which refers to altered sensation in half of the body. Patients often perceive senses that may not be occurring, so they suddenly have pain or a sensation that something feels hot. This is another element of this chronic pain syndrome on one half of the body you can see in someone who's had damage to their thalamus. And there's basically two major ways this thalamic syndrome occurs. The first is from a posterior cerebral artery stroke, which is a rare type of large vessel stroke. You can also see a thalamic syndrome from a lacunar stroke, which is a small vessel stroke, and we're going to talk about that later in this video. Okay, so those are the three major large vessel stroke syndromes involving the cerebral cortex. Now what I'm going to do is talk about some other ways you can have damage to the cerebral cortex outside of ischemia involving one of those three major vessels. And the first thing I'll talk about is hypoxic encephalopathy. This refers to brain damage from hypoxia. That's why it gets the name hypoxic. And usually this occurs because of loss of blood flow to the central nervous system. So if you cut off blood flow to the central nervous system, a patient will lose consciousness in about 10 seconds. and there will be permanent brain damage after about 4 minutes. And the reason neurons can only survive for a few minutes without blood flow is because they can't store glycogen, so they are very dependent on a constant supply of oxygen in the blood. When there's decreased central nervous system blood flow to the entire brain, this often leads to severe neurologic consequences, things like coma and permanent vegetative states. And the main reason this often happens is because of shock. When there's any form of shock and there's very low cardiac output and very low blood flow, this leads to ischemia of the entire brain and hypoxic encephalopathy. You can also sometimes see hypoxic encephalopathy in patients who do have enough blood flow to the brain if there aren't enough nutrients in the blood. So if patients are severely anemic, they can develop a picture of what you'd get from loss of CNS blood flow. They have enough blood flow, there's just not enough oxygen in that blood. Same thing can happen in patients who have severe hypoglycemia. They cannot deliver enough glucose to the brain, and that can develop a sort of encephalopathy type picture. When there's decreased blood flow to the brain, certain structures are more vulnerable to that loss of blood flow than others. So let's talk about that now. These things are high yield to know for your board exams. So the hippocampus is famous for being highly vulnerable to loss of blood flow. Specifically, it has cells called pyramidal cells that are the first damaged cells when there is loss of blood flow to the brain. Some people remember this by the mnemonic, the hippocampus is first to go. The reason for this is because the pyramidal cells are neurons that have very high energy requirements, so they need a constant supply of oxygen and glucose. And the hippocampus is a structure in the brain that's important for learning and memories. And so when you have damage here, patients can develop anterograde amnesia, which is a specific type of amnesia that I talk about in other videos. Another structure that's famous for being vulnerable to ischemia is the cerebellum, shown here in this picture. It has cells called Purkinje cells that are also very dependent on oxygen and glucose, and so they're highly susceptible to ischemia. And then when you have damage to the cerebellum, this leads to problems with balance and ataxia. And then finally, the neocortex refers to basically the major regions of the cortex of the brain. And histologically, it can be divided into 6 layers. And it turns out that layers 3, 5, and 6 are the most vulnerable to hypoxic damage when there's loss of blood flow. So all those anatomic regions on the last slide are highly vulnerable to ischemia, but another section of the cerebral cortex that's highly vulnerable to ischemia is the so-called watershed area. So let's talk about that now. So the watershed area refers to the most distal branches of the major arteries. These are the regions that are furthest from the aorta, and so they are the first to lose their blood supply when there's a decrease in blood flow. And when patients have damage to these regions of the cortex, we call it a watershed infarct. This basically means ischemic damage to the border zones between the MCA, ACA, and PCA that are supplied by these deep distal branches. And the classic scenario where you can have ischemia to these portions of the cortex is after a massive myocardial infarction. There can be a severe drop in cardiac output. The cardiac output comes back up and the patient recovers, but then they have neurologic deficits, and the deficits are located in these watershed or border regions that were the first regions to lose blood flow when the patient had their cardiac output fall. And if you look at this image on the slide here, it's got colors depicting the regions where you have blood flow from the MCA, which is the green section, the ACA, which is in purple, and the PCA back here, which is also sort of in purple, but a different shade. And so these border regions in here, which I'm marking with my pen, are the regions where deep branches of the major vessels supply blood. And those are the watershed regions where you can have damage when patients have a watershed area infarct. So in terms of clinical features, a watershed area infarct is going to lead to bilateral symptoms because you've cut off blood flow to the entire brain. You're not just going to have symptoms on one half of the body or the other. Both sides of the body are going to be affected. And it turns out that the neurons in these watershed areas often control the proximal limbs, like the shoulders and the thighs. You don't find a lot of neurons in these regions that control the face, hands, and feet, so those regions are often spared. So the clinical presentation of a person who's had a watershed area infarct is sometimes described as a man in a barrel. Basically, the patient is able to move their hands and feet, but they can't lift their arms or legs, and that's because of weakness of the proximal portion of the limbs. And here's a nice picture shown here on this slide of someone who's had a watershed area infarct. These little white regions represent ischemic damage, and you can see that it doesn't involve the entire half of the brain like you saw in that MCA stroke we looked at earlier. It's these small regions that are in the border zones between the different large vessel blood supplies. What I'm going to do for the rest of this video is talk about lacunar strokes. And lacunar strokes are a special type of strokes that do not affect the cortex. They affect the subcortex. I'll explain what I mean by this in just a minute. But I'm going to talk about them in this video on cortical strokes because distinguishing lacunar strokes from cortical strokes is one of the harder things to do as a medical student. And so we'll talk about the contrast between cortical strokes and subcortical lacunar strokes in the next couple of slides. In general, lacunar strokes affect an anatomically small region of the brain. They don't affect a big swath of territory of the brain like we saw on that CT scan from an MCA stroke earlier in this video. And lacunar strokes are strongly associated with hypertension. By and large, these mostly occur in patients who have poorly controlled blood pressure. The reason they're called lacunar strokes is because after the stroke resolves, it leaves behind a lacunae, which is a Latin word for an empty space. So this is an example of what one can look like grossly here. You can see this space left behind in the brain from a lacunar stroke. And these strokes are so small that they often don't show on the initial CT scan. So if a patient presents with clinical features of a lacunar stroke, the initial CT can be normal. They are best identified by MRI. And then you should also know that although they are strongly associated with hypertension, they also have an association with other vascular disease risk factors like diabetes and cigarette smoking. Okay, so the infarctions from lacunar strokes, as I already mentioned on the last slide, are non-cortical infarcts. So you are never going to see cortical signs from a lacunar stroke. And if you understand that, that makes recognizing these strokes clinically so much easier. These strokes are very different from ACA, MCA, and PCA strokes that can have cortical signs and affect a large area of brain tissue. And so just to give you a picture in your mind, let's look at this image shown right here, which shows the middle cerebral artery. That's a large blood vessel, and if you have a stroke involving this vessel, you're going to get a big region of ischemia involving the entire cortex. In contrast, lacunar strokes involve these little branches like these ones shown here. And so if you get a stroke involving one of these little branches, what you're going to get is, first of all, a very small region of ischemia, and it's not going to involve the cortex out here. It's going to involve the subcortex down here. And that's what you see in lacunar strokes. These are strokes caused by ischemia of very small vessels that are branches of the big cerebral vessels. So what are some of the specific blood vessels involved in lacunar strokes? Well, the most important one to know is the lenticulostriate branches of the middle cerebral artery. If you look at this drawing on the slide here, this is the middle cerebral artery, and these branches here are called lenticulostriate arteries. And those are the most common vessels to be involved in lacunar strokes. They're going to give you a small region of ischemia in the subcortex. You can also have lacunar strokes involving these vessels shown right here. I think it's fairly low yield to memorize all of these names. The only name I would memorize is lenticulostriate branches because those are the most common location for lacunar strokes. But I do want to point out that these paramedian branches of the basilar artery, which are shown here in this image, they supply regions of the pons and the cerebellum. And so as we'll talk about in a minute, lacunar strokes often involve the pons and the cerebellum because of these branches here, in addition to the basal ganglion internal capsule up here because of vessels like the lenticulostriate arteries. In terms of pathology, the cause of lacunar strokes is degenerative changes in those small penetrating arteries we talked about in the last slide. And the hallmark pathologic finding is lipohyalinosis. This refers to narrowing of small blood vessels with hyaline deposition in the blood vessel wall. The blood vessels will show a thickened wall, and the walls will be eosinophilic or pink. This is an example of a small vessel with lipohyalinosis shown on the slide here. And you can imagine when the blood vessel gets this narrow, it's very easy for it to become clogged by a thrombus, and that's going to lead to a small area of ischemia in the subcortex, and that's what a lacunar stroke is. So let's talk about the locations in the brain that are often damaged in lacunar strokes. And to start with, let's look at this image up here. So remember, cortical strokes like MCA strokes, they're going to affect big swaths of the cortex out here. The common locations for lacunar strokes are these subcortical regions down here. So what can be damaged when you have ischemia in this region down here? Well, first of all, you can damage the internal capsule. The internal capsule contains upper motor neuron fibers that supply motor innervation to muscles. So when you get damage to the internal capsule, this can cause dense hemiparesis that we talked about earlier before on the contralateral side of the body. Also in the subcortex, you find the thalamus. And so if you get damage to the thalamus, this can lead to sensory loss in half of the body. And this is that thalamic syndrome that we talked about earlier, a common sequelae of someone who has a lacunar stroke. And then as I already mentioned, the pons is often damaged in lacunar strokes. When you get damage to the pons, you can get dense hemiparesis from damage to the corticospinal tracts. There are also fibers in the pons related to the cerebellum, so this can lead to problems with ataxia. And then finally, the basal ganglia are all found here in the subcortex, so they can be damaged by lacunar strokes. This can lead to various movement symptoms. But really, in terms of clinical features, the dominant features of lacunar strokes are these things shown up here. They're related to damage to the internal capsule, the thalamus, and the pons. Okay, so next let's talk about the clinical features of lacunar strokes. And there are 5 subtypes of lacunar strokes. They're all listed here on this table. The best way to get good at answering questions about these 5 subtypes is to do the associated questions with this Boards and Beyond video right after you finish watching the video. We have questions on each of these subtypes, and that will teach you how to recognize them in question stems. But now let's go through each of the subtypes one at a time. The first subtype is the pure motor subtype of lacunar stroke. This is what happens when you have ischemia involving one of those small blood vessels that damages the internal capsule. So these patients present with dense hemiparesis and paralysis of the face, arms, and legs all on one side of the body. And remember, this is different from MCA and ACA strokes, which damage regions of the homunculus. They don't present with dense hemiparesis. They present with hemiparesis that's more predominant in the legs or the arms or vice versa. Second type of lacunar stroke is a pure sensory stroke. This happens when you have damage to the thalamus. We talked about this earlier. This leads to a thalamic syndrome. So this can present with numbness and sensory loss on one side of the body, involving the face, arms, and legs. The third type is a mixture of the first two. It's called sensory motor. This is what happens when you have damage to the thalamus and the internal capsule. Also in this subtype, there is sometimes damage to parts of the basal ganglia, like the caudate and the putamen, and also sometimes the pons. But the clinical features you're going to see are paralysis and sensory loss, basically a combination of the clinical features of the first two subtypes. Fourth subtype is called ataxic hemiparesis. This happens when there's damage to the base of the pons and the internal capsule. As the name implies, it presents with weakness on half of the body. That's the hemiparesis. But also the patient will have dysarthria, which means difficulty using the muscles of speech. So the patient has trouble speaking. This is different from aphasia. It's not a comprehension of speech problem. It's merely a problem moving the muscles associated with speech. And then finally, it's called ataxic hemiparesis because the patient often has ataxia or balance problems. This is from damage to cerebellar fibers running in the pons. And often the ataxia is out of proportion to the weakness. That's why it's called ataxic hemiparesis, because the ataxia tends to predominate. And then the fifth syndrome is similar to the fourth one. It's called dysarthria or clumsy hand syndrome. This also involves ischemia at the base of the pons and the internal capsule. It's called dysarthria clumsy hand syndrome because the patients have dysarthria, which, as I said, is a speech problem. And then this tends to mostly involve motor fibers related to the hand. So the dominant features are clumsiness or weakness involving the hand. And that's why it's called the dysarthria clumsy hand syndrome. And once again, after this video, go do all the Boards and Beyond questions associated with this video, and that will help you really nail down these 5 subtypes of lacunar strokes. Let's talk briefly about hemiballism, which refers to wild flinging movements of the extremities. These are called ballistic movements, and it's called hemiballism because you see these ballistic movements only on half of the body. This can happen rarely in lacunar strokes when there's damage to the subthalamic nucleus. This is the subthalamic nucleus shown right here. It's a component of the basal ganglia that I talk about in detail in the basal ganglia video. But in rare subtypes of lacunar strokes, you can have damage to this subthalamic nucleus, and the patient will present with wild flinging movements isolated to half of their body, and this is referred to as hemiballism. So the classic clinical picture of a lacunar stroke to know for your board exams is going to be a patient with uncontrolled hypertension who presents with symptoms that are consistent with one of the 5 lacunar subtypes. Often it will be a patient with pure motor symptoms where the legs and arms are both affected from damage to the internal capsule, or it will be a patient with pure sensory symptoms where the symptoms are caused by damage to the thalamus. These are the 2 easiest subtypes to write board questions about, so make sure you're familiar with those. As I said earlier, these strokes affect a very small region of the brain, and the initial head CT is often negative. CT is much more sensitive to bleeding than it is to ischemia in general, and it's especially insensitive to very small regions of ischemia. Incidentally, if the initial head CT shows symptoms that look like a lacunar stroke, but you see blood, then that patient has had rupture of a Charcot-Bouchard aneurysm, and I'll talk about this in just a second. And then finally, remember that MRI is the gold standard. It can usually pick up these small lacunar strokes. And so I'll finish this video with one slide on lacunar strokes compared to rupture of a Charcot-Bouchard aneurysm. I talk about Charcot-Bouchard aneurysms in detail in the video on CNS aneurysms. But by way of review, both lacunar strokes and Charcot-Bouchard aneurysms affect the same vessels, those small penetrating cortical vessels. And when you have a lacunar stroke or rupture of a Charcot-Bouchard aneurysm, you can get similar clinical features, all those things we just talked about in the last few slides. Also, both lacunar strokes and Charcot-Bouchard aneurysms are associated with hypertension. So in terms of board questions, if you see a patient described as having symptoms related to ischemia of deep cortical structures, it could be a lacunar stroke or a Charcot-Bouchard aneurysm that has ruptured. The only way you're going to tell those two apart is by imaging. On imaging, a lacunar stroke usually presents with a negative CT scan or normal CT scan. In contrast, if you have rupture of a Charcot-Bouchard aneurysm, CT is very good at identifying blood, and it will show blood in those deep cortical structures. So make sure you understand that these two pathologic processes affect the same vessels and can lead to similar clinical pictures. The major way you distinguish one from the other is by CT scan or MRI, depending on whether it shows blood or an absence of blood. And that concludes our module on cerebral strokes.